Thank you. I'd like to thank the ChanRe group for asking me to be part of this wonderful meeting today. Rheumatological diseases are the most complicated diseases because they don't have one phase. The disease does not present just as pain, there's loss of function, there's loss of employment, because the majority of these diseases are known to affect people in their most productive years of life. Assessing diseases is one of the most important aspects of treatment in rheumatology, and it's not easy to do because gone are the days when we ask the patient, are you well, do you have pain, is the pain gone? I think we have moved beyond that now to achieve remission of the disease as much as possible. So there has been a constant quest in finding out new ways of assessing patients. No one method is correct, but practicality is also important to see how best we can assess our patients, because much of the published literature is Western. So in order to tease out these important aspects, we have a wonderful set of topics listed today by Dr. Chandrashekara and group. And this would be describing how to assess rheumatological diseases in an outpatient clinic. The first speaker we have today is Dr. Chandrashekara himself. He needs no introduction. Most of you know him very well. But still, for those of you who don't know him, he is currently the medical director and consultant rheumatologist and immunologist at ChanRe. He graduated from Mysore Medical College and did his DM from Sanjay Gandhi. He has worked as professor and head of the department at Ramaya. He has numerous publications to his credit and is an investigator in multiple drug trials at the moment. He is a reviewer of many national and international journals, and also is the editor of the ChanRe Journal of Rheumatology. Dr. Chandrashekar will be speaking on introduction to the concept of measurements in rheumatology. Over to you.
Thank you. At the outset, let me welcome all of you. And I will be, in the next 20-25 minutes, I will try to speak on what exactly and why we should measure when it comes to managing rheumatic diseases or any other disease per se. The major fallacy which most of us practice sometime when it comes to rheumatic diseases, we still practice it more like an acute care when it really a chronic disease. Something what we call as a model of 19th century being used at 21st century. See, what exactly we meant when we try to manage an acute disease versus a chronic disease. When it comes to acute disease, we are very clear there is a resolution at the end of the treatment. When you treat it, when you treat a sore throat, you know in the end of the day, the sore throat resolves and there is no more infection at that site. But that's not what is expected when it comes to chronic disease. We are sure probably patient may relapse with the disease, or patient may continue to have this particular change through his life. And we are sure about the etiological agent in many of these circumstances in acute disease. Though we know causes, we know the etiological factor, we try to define the factors, we are still pondering upon, is that etiological factor is resolvable? Can I switch on or switch back? There is an essential hypertension. We know there are refluxes which are changed. We know this could be the change, but we know that it is not going to resolve. So that's where we might have defined defect, but we may not be still thinking that it is resolvable. And as it is in acute disease, treatment is short and normally within a predefined set time. So usually it ends by a week, 2 weeks, a month, or a month and a half, or 6 months if it happens to be tuberculosis. You have a predefined set of time. But when it comes to the chronic disease, management process is continuum. It is almost throughout the life, and whether he has it or he doesn't has it needs to be monitored for the disease process through his life. So precisely any chronic disease, whether rheumatic or any, it's a lasts lifetime, accumulates with the age, the problems associated with the disease gathers on as it with the age, and usually progressive. It adds on to the trouble which has already set in the very initial state. And it may shape the life through in a predictable manner. You know, after some time his hand's going to deform. You know, after some time the knee may break down. Or after some time his mobility is going to get restricted. So these are what we can say, these are usually, its last lifetime, accumulates with the age, generally progressive and can change the life. I mean, it could be a life-shaping kind of diseases. So thus, when you treat a condition, acute or chronic, whatever, usually we have an objective to treat. When it comes to acute, you want to resolve the problem. When it comes to chronic, we need to manage the disease. That's where we are. And we need to define ourselves what is the expected outcome. What are you going to do with reference to the disease that you are managing? And you need to define the targets precisely. What are you going to do? And is there any preventable aspect when it comes to the state of management? Do you have something which can prevent a problem that's likely to occur? So in a goal set in a chronic disease care is you need to manage the disease exacerbation. In a comes to rheumatoid arthritis, you would like to prevent him getting acute crisis of pain. You need to prevent him getting the swelling, stiffness, worsening time and time out. And also to prevent the transition from impairment to disability and disability to handicap and finally being bedbound. So the primary intention when it comes to a rheumatic disease or a chronic disease care of this nature is you are trying to avoid the exacerbations, and also you are going to avoid the transition from what starts as an impairment to a disability and from then on to handicap. So when it comes close to the rheumatic disease, you try to look in the relief of symptoms, the pain, the stiffness, the disability, the difficulty to walk or do the movements and mobility, and to relieve these symptoms, and simultaneously the prevention of disability, to prevent the disability occurring, the development of the deformities, and simultaneously we need also to focus the lesser adverse reaction to whatever the intervention we plan or propose, and improving the quality of life, and simultaneously look at the life expectancy being improvised from what is expected out of these rheumatic disease. So the question remains is how to achieve it, and also we need to know, are we in the right path? We are using disease-modifying anti-rheumatic drug, we are using intermittent spurs of steroids, we are trying to use some of the biologics in between to treat these particular patients. Are we really in the right road? Are we doing the real justifiable thing, or is it just another way of controlling the symptoms? Is it that DMR just gives you a pain relief? What could have been done by an NSAIDs or a steroids? And what is the way to achieve it? Is there a way to achieve or get these things in place? So the approach and expectations, and when you are doing an expectation, you need to do the measure of the success. See, if you look at the short-term impact, it will be obvious. For example, when you are trying to care the symptoms, when it comes to rheumatic disease, at least we have pain, swelling, stiffness, which will be obvious when you intervene to the patients. Patient symptoms, pain, everything comes down, patients feel comfortable. But the condition like diabetes mellitus, which we manage for a long term with a lot of drugs interspersed, we do not have a symptom which is acute and precipitating and reflecting except a transient hypoglycemia or episodes of ketoacidosis or episodes of burning and other symptoms which more of a complication rather than of the disease. In rheumatic disease, at least we have an acute short-term impact when you are manage these set of patients. So you have a clear-cut defined expectations when you are trying in an acute short term. And simultaneously, we know that this change, what happens, is appreciated by the patients. Patients are very clear after this particular drug given, his pain, stiffness and symptoms has come down. So also ourselves that the patient is feeling good. But when it comes to the long term, usually what is likely to happen is expected rather than what is visible to all of us. We expect a rheumatoid arthritis patient to develop disability, deformities down the lane in 10 years. It may happen, may not happen. When it comes to diabetes mellitus, we have that concern for the expected complications or a sequelae of the disease process, which is not apparent, and neither it is appreciated instantly that these changes are likely to happen. It is being prevented at this point of time by this intervention. This puts both the patient as well as the treating physician at dark. So especially the treating physicians often educated and know about it. He knows what is he trying to do about it, but the patient feels that what is likely to going to happen if I take these medicines, especially in rheumatic diseases. Once the pain is off, when he insists him to continue with the disease-modifying anti-rheumatic drug, the question patient raises that why should I continue to take, sir? My pain is gone, my symptom is gone, my stiffness is gone. What exactly we need to know? And it also pursues the treating physician if he is not aware about that. If it is not continually managed in that way, likely he is going to develop. So we need to know when it comes to a long-term impact, both the patient as well as the care provider need to know what is the long-term impact. Whereas in a short-term impact, in acute diseases, we know each other that this is the changes that's going to happen, and it's quite obvious both to the patient and the provider this change has happened. And as I said, the short-term impact in rheumatic disease can easily be managed by symptom-modifying drug. When it comes to the long-term impact, we need to modify the disease process. The disease process needs to be modified over a period of time, which in turn reduces the long-term impact of these particular disease processes. How exactly to appreciate this? See, it's very difficult for us to appreciate this particular concept. How exactly it happens? What do we mean by measures? What do we mean by the target? To explain this, there is a concept what is called as clinical glide path concepts. What do we mean by here is, you tend to observe one or more parameters at the current status, which predicts the expected state or the outcome. See, what we meant here is, you keep the target what can be visible or made visible at this point of time, looking at the changes if you do in that is what is the change that's going to happen if he is seen through in the next 10 or 15 years or 20 years. So what we meant here is, it's a tool which is used to improve the communication between the treating physician as well to the patient. So in a sense, you use a measure which helps you to communicate to the patients, look, this is what has been achieved, this is what is likely to happen to you. So in this, when you have these kind of measures, you have a precise definitions, then you know what to do. If it is within the expected pathway, you need not do anything. If it goes out of the pathway, you need to trigger a change or a variations. So let me use a well-known, well-appreciated clinical model to explain this guide path. See, all of us are very clear when we are managing diabetes, we are trying to manage the patients of a glucose level at that point of time for a worry of microangiopathy, nephropathy, retinopathy, chronic cerebrovascular disease, as well as reduction in life expectancy if glucose levels are not maintained. If you look on the day-to-day basis, the minor variation of the sugar, even up to 300 or 400, patient may not be symptomatic. And patient becomes symptomatic. On the contrary, the drop in the glucose levels where patient become hypoglycemic and become symptomatic. But yet, we talk of what we call as a good control. We try to take a measure at that point of time. We have three ways to measure it that, a urine sugar, or a blood sugar, or a glycated hemoglobin. We have three parameters on which we try to measure how good is the control of the diabetes or a sugar at that point of time. We talk of at that point of time because that is what is apparently visible for us. We will never be able to make out whether there is a development of microangiopathy at the point of time of managing the first few years. And we will never be able to make out the nephropathy and other changes at that point of time. So we know you can check urine sugar, not very sensitive and specific. We have dropped it off. And we look into the blood sugar, random, fasting or postprandial. We do know there are certain small fallacies. There are sensitivities is good. Specificity is precisely not as good as you can check with glycated hemoglobin, which gives an average figure of 120 days. So keeping this path, what we try to do is a good control or a bad control. As long as patient maintains a very good glycated HB in and around 6 to 7, we are happy with it. Whatever the OHA we have started, it is continued. The day you see that GHB is going wrong, it's on the higher side, you tend to rectify, tend to change his lifestyle. You tend to shift from OHA to insulin and try to bring back the GHB back on track with a hope and intention that these are going to prevent these targets. So when it comes to the rheumatic disease, we need to have such targets. We need to have a well-defined targets. Why we didn't speak about in the last 10, 12 years, you might have attended various of our conferences and meetings. We never spoke about that because we are still pondering upon what to do. And of late, from last 2, 3 years, things are more well defined. Now we are more clear what to see at this point of time, which can reflect in long term. It may change over a period of time. As I said, we started with urine sugar, then we moved to the fasting and random sugar. Once the glycated hemoglobin became more popular, more available, we have shifted to glycated hemoglobin. That is also expected when it comes to the rheumatic disease. I will tell what is right now, may change my talk when all of the speakers who are going to talk may change their talk. After 5 years, there may be something else which could be a different marker, but let's follow what it is right now so that it helps. So how does it when it comes to the rheumatic disease? What do we talk when it comes to rheumatic disease? Our worry when it comes to the rheumatoid arthritis is the deformities and disabilities and the development of extra-articular complications. And we are also aware continued inflammation in rheumatoid arthritis is going to increase cardiovascular death. And we are also very clear it reduces the life expectancy. How are we going to achieve that? And we can't foresee that at the point of the beginning. What we can measure at that point of time is a disease activity. What is the status of the disease activity score? We check on the disease activity score, try to look whether it is within the range of a good control or away from the good control. Over a time course of period when you are trying to follow him up, we can start with some of the disease modifying anti-rheumatic drug, keep track of what is the disease activity which is going on. Based on the disease activity, if it dips down, you can change from one way of treating to another way of treating. We have what we had last 15 years of a few disease modifying anti-rheumatic drug. We have a good array of disease modifying anti-rheumatic drug including biologics. This has made us to much more well equipped to alter the disease activity score as and when it fails. So we can change and switch from a therapy regime A to therapy regime B to C or use biologics or a combinations so that in the end you keep track of disease activity score within the time frame of permissions. Let me tell you why it is slanted down. It's been seen either in diabetes as well as in rheumatoid. Despite we keeping the patient in this track, still there is some amount of decline. And it's been seen even in the good number of diabetic patients up to around 10 to 15% whose chart as retrievable from the history of the patient is though are under good control, we still see 5 to 10% of them developing the complications. So also in rheumatoid arthritis, there are exceptions of 5 to 10%. That's why the glide path is always directed downwards. Hopefully if we can make it flat with the measures, we would all love to have it. But currently as we stand, the glide path is always downwards, but this glide path is long, stretched and prolonged to an expected levels when you manage the patients well within an expected target. So what we are looking at when we are trying to manage rheumatic disease, it's not just the symptom, it's not just the pain, it's not just the swelling. It's overall, we would like to know whether patient's disease is under control. So if we can achieve that, probably we will be able to achieve the expected endpoint, which is not visible, but it is one of the very important target which we need to keep when it comes to management of rheumatic disease. So what I meant here is, we have a habit of measuring everything. We measure beauty with some of the definitions. We have a way to measure dosages. We tend to measure the temperature. Even for that matter, we grade the happiness very well, nice, and we measure everything, including the success. When we are trying to treat a patient on a rheumatic disease, we need to keep a measure because that's the one which is going to guide us through the pathway that what exactly we are doing. So what we meant here is we need a target. We need to keep a specific target, precisely what it is to be done, because the target what we are looking is apparent and long. It's not that the moment the exercise is started, you get the dimension. The target is that you start working on that. You look into the time, you look into the success. We measure everything, and we need to measure the disease activities, even rheumatic disease, which precisely put us onto the target, so that what is expected to be achieved is measured at this point of time, and the change in treatment are altered as required at that point of time. Thank you very much.
Thank you, Dr. Chandrashekar. Are there any questions from the floor? I'll start off. It's not just rheumatology, but measuring disease activity is not easy with any disease. It's very inadequate in clinical practice in India. For example, you take diabetes. apart from blood sugars and maybe a HbA1c, most patients don't go beyond that. We hardly see patients who've meticulously been monitored for microalbuminuria or fundus, so on and so forth. What's going wrong with Indian physicians? Where are we lacking? What probably do you think is the reason that we're not able to measure disease activity in any of the diseases to the international standards?
No, I mean, I can tell you that this is not the problem which is just with reference to Indians or Indian practice. It is there all across the globe. I mean, I think when I was trying to review on these issues, measures and those, I could see there were around 15 articles published in 2013 and even in 2012, which was trying to figure out why there is a wide gap between the academia type of management versus the practice at the healthcare delivery system. And what it was trying to say that there was a measure from 2 articles from US and 3 from UK and 1 or 2 from the European countries. Of course, I didn't see much from Denmark and Scandinavian countries. Probably, I don't know whether they really manage it pretty well because it's one of the supposed to be well documented system which happens. And in this hospital management things, they were saying that there is a gap of around 30% to 70% difference in the way an academic institute manages, checking on these parameters, etc., when it comes to rheumatic disease, even cardiovascular disease, hypertension and diabetes, vis-a-vis what happens in private practice. And there is a way they're trying to work out how to bridge this huge gap which exists between what is right and what is practiced. So probably, I mean, this is one of the initiatives why I thought that it's a time we start talking about that and trying to push it hard to say that this is the best way to manage it. It really doesn't cost much. So basically, I think once all of them going to go for giving the how to measure the disease activity, we do appreciate that the cost of measuring is not that expensive as we expect. And if you look into the cost-benefit ratio, there's a very wonderful article where they have analyzed. If you manage with the expense of, say, around, it's around $30 in US to do this GHB, and I think here it is still much lesser for us. With that expenditure, if you look into the complication of nephropathy and others you see, and the expenditure that is expected, it is much, much lesser. It almost dips down by 30 to 50% of the expected expenditure. The problem is probably the groups who are working with academics should push it hard to educate and put things in place with the primary care so that it can be brought in place.
Thank you. Any other questions? Sir.
I'm Dr. Kasturi, physician. I would like to have a comment, not a question. See, today the chronic disease management is going to be a major threat to every level of care. And the chronic disease can become an acute process or continue to remain. And as he very rightly pointed out, and I would like to compliment the speaker for inciting an important issue which all of us should be aware. 1 or 2 suggestions from my side is about the cost cutting. The tendency of many of the institutions is to do every test to every patient. We are sure we follow up a chronic disease for a long time. All diseases do not target the same organ at the same effect. So it is for us, the treating clinicians at various levels, to go with the patient, to reduce the cost, contain his cost. I think we will be able to address it to a large extent. Second suggestion from my side will be, whatever you may say, unless you sensitize the caregivers and you involve the patient in management, the success of chronic disease management falls down more than 50%. I have not done any studies, but by experience I find involving the caregivers, whatever they are, because a lot of societal changes are occurring in healthcare delivery to the elderly. And these 2 aspects too can be kept in mind to improve the healthcare.
Sure, sir. Thank you for your comments. Point well taken. I'd like to thank Dr. Chandrashekara